ACOs I have. So I don't have those physicians, but I have a lot of the other the groups, a lot of the other 20 ACOs in California. Most medical groups do not have a pharmacist. And when I talk to them, these groups, they want a pharmacist, but they don't know quite what to do with them if they had them. So they don't know, well, what does that program look like? Okay, I've got a pharmacist now, what do I do with that pharmacist? So we decided to figure out how could we fill that gap, how can we help? So we hired some advanced practice pharmacists with their own established practices to help jumpstart these groups. These pharmacists have busy practices of their own. They're seeing patients daily. They have full patient loads. They have prescribing authority. So they can really speak like boots on the ground. They're doing it currently. They're keeping up with things. They know all those nuances and little tips that could really help a group go, oh, okay, I get it. And they bring so much value when we bring them into a group. They meet. When they start out, they meet with all the stakeholders. So they talk to the physicians, they talk to all, any of the stakeholders in the group or the hospital, and start to kind of interview them and see where their pain points are. And then they provide, they do a deep dive on the pharmacy data, of course. So that's where Blue Shield comes in. We give them pharmacy claims data and medical data so they can get a real field landscape on where the gaps can be and where the pain points are. And then they provide them all the underpinnings to set up their program, a customized program, based on what the group needs. So they give them their protocols, they give them their workflows, they give them scripts if the pharmacist is going to be calling the patient or calling the doctor. So they really just kind of set up that whole skeleton for the program. So it's kind of ready to go, and the group doesn't have to trials and failures. They're going to use something that those pharmacists are using today, and then they have these successful practices. So it's always good to have these tips and things from people that are doing the work today. Another thing they do is they mentor that pharmacist. So if a group is just getting into having a pharmacist, these guys are truly available 24/7 for that new first pharmacist has come in. So they're there, as they're seeing patients, as they're talking to doctors. They can email them, they can text them. I think they answer them on weekends if they want. They're there to kind of support that pharmacist and give them a safety net. Additionally, we also like to keep some key focuses on these programs. So what we add to this consulting service when we bring these pharmacists in is we want to make sure they also cover some key areas. And that for Blue Shield are ones that we're all concerned with: hypertension, diabetes, and then narcotic utilization. So we'll look at, as these programs build, they will also bring the underpinnings, the algorithms, the workflows around those three conditions as well. Okay, this is an example of just one of the pilots from last year. And this is pretty typical, and this isn't, they found an average of seven recommendations per patient, 6 to 7 recommendations per patient for everyone they looked at. 75 to 85% of the recommendations were accepted by the physician. And this one I find interesting in that 38% of the interventions were just stopping a medication. I mean, there's a huge problem with this episodic care where prescriptions build up over time with the patient, and just having someone take the time to just take the time to go through it and go, oh, well, you don't need that anymore, is just incredibly valuable. It's time consuming. Okay, I've got just a little bit of time. Let's see. What we learned from this program, we did 3 of these last year. We learned to keep the executive steering committee in the loop. We start off with these programs and then out of sight, out of mind. So now we have steering committees, so the decision makers of the group, we meet with them regularly as a team so that if we have any problems with the program, they can immediately address it. And they also I wanted them to hear our successes. So they've got this pharmacist out doing great work. We want to make sure that they know about it and that, that it's the start of expanding that program as well. Finding the right pharmacist. A lot of times we started with maybe the group had just hired pharmacists. Right before we got the consultants on board, we decided to do this program. It's really important to find the pharmacist is a good fit. And so with the pharmacy board having advanced practice pharmacists, potentially being licensed in July, I think that they're kind of on track to do that, is finding, if you're going to have pharmacists doing this sort of work, you probably want to have them advanced practice pharmacy certified. And then we always suggest where a good placement for the pharmacist is, and I list some here. But one thing we did learn is it's not one size fits all. So when we go in and do this evaluation, there may be areas that the group really wants a pharmacist that maybe aren't one of these, like a refill clinic. If they've got a refill clinic set up and they want to make it better with a pharmacist, maybe that's where we go. Or they want an anti-coag clinic, something like that. Okay.
Can you back up to that slide for just a moment?
Sure.
So you said suggested target populations to consider. As you think about the number of heart attacks and strokes and diabetic complications that we have in the state, we know we have 81,000 deaths in those three categories. Many of them are preventable.
Yeah.
As you think about your experience, what would you say in terms of policy, because we do have some policy people in the room, should be what the state is looking to for which patients should be getting those services?
Well, in a commercial population, we did similar to what Marilyn has mentioned. We analyze the claim data, and we can drill it down to those patients that we know need service, first tier, second tier, third tier.
So who are they?
We can look for gaps in care. We look at their risk scores. We do a variety of algorithms against them.
So you say high-risk hospital discharge patients.
So our medical director is very big on a pharmacist seeing every patient post-discharge. So that is probably the number one place we want to place the pharmacist, is they're either calling them or seeing them in clinic. Maybe that phone call and then evaluating, whoa, this person also needs to be seen in the clinic, and they need to be seen in the clinic maybe for 6 months. They need some individual attention by the pharmacist.
Hattie, to answer your question though, our medical director, some of the examples that he gives for this high-risk population is your cardiovascular disease post-MI patient, your CHF patient, your COPD asthmatic patient, and everyone's known frequent flyer folks that come to the ER and to the hospital. And so those are some of the populations that one wants to target.
So the Kaiser data here is outstanding. About 85% of the patients with a pharmacy directed program become under control for their hypertension. I worry about that 15% that's beyond that. Even with the best program out there, have you involved health coaches for the non-adherent patients? That other additional 15%. So how do we even do better than that?
I think that's a good question. I mean, we're blocking and tackling the pharmacists in there and start seeing that first 80%. Yeah, it's good thought. Okay, so just a couple, I've only got a few minutes left. The last one is just what we're going to be doing the rest of the year. One is virtual advanced practice pharmacy services. So again, I'm looking at groups that don't have pharmacists today. What we want to do, and we've already kind of put together a workflow, is bringing certified advanced practice pharmacists into the group virtually. But one of the things we're realizing is we're going to have to really know that virtual pharmacist and really integrate that communication between the physician, the patient, and the pharmacist that's going to be calling. So we know it's really important that that physician or someone that knows that patient very well says, hey, this phone call from the pharmacist is very important. You need to participate in it and expect that call, and this is the phone number that's gonna be on your phone, and you can pick it up if you need to talk to them. So our pilot for using advanced practice pharmacists virtually is, we're gonna kind of help the group, with our credentialed pharmacy network, you have pharmacists available for these groups to use, but then have a really tight, trusted communication between everyone, so that is not a cold call. It's like just a virtual care team effort, similar to what Hill is doing, but then Hill is using their own physicians, so we would be kind of supplementing that at Blue Shield. And also, we're talking with all the pharmacy schools, so advanced practice pharmacy, we think is gonna explode in July. So, the schools wanna have practice sites for their students, the doctors would like more pharmacist help, so we know there's a lot of synergy there, and so we're going to be working on that to see, because I think Blue Shield is in a good position to talk to the schools of pharmacy, and we know the groups already, we're meeting with them all the time, and what can we do to bring this together? That's all. Any questions?
Looks like you've got quite a few. Tori?
So I'm just curious, of anybody that's been looking at the utilization of pharmacists within the practice setting, has that had any impact on access? Meaning, are patients able to actually, has that freed up any of the primary carers to actually have greater access because they have a support team around them that's able to take care of some of the patients? Has anybody done any research around that?
No, anecdotally, that was we did a survey with our pilots last year. That was one of the responses from the physicians, was that they love being freed up and hand that patient off. So I'm assuming that gives them more time to work with the patient on other things.
Okay.
Yeah.
So you did have physicians say that, and dentists, yes.
Yeah, and just to add, I think some of the literature recently on pharmacists' involvement, especially in the patient-centered medical home, has demonstrated that some of these patients had, in terms of patient satisfaction, have noted that there is improved access, and they're much more satisfied with being able to access a healthcare provider there.
I think intuitively people think that that's the case. I just wonder if anybody has any quantifiable data, because the shortage of primary care is we're all trying to work towards solving, and it's not by adding more doctors.
I could share with you that prior to coming to Blue Shield, my colleagues and I did an independent analysis of a pharmacist in a patient-centered medical home at Sutter Health. And there, that analysis did demonstrate that those patients that were being seen by a pharmacist tended to have an increase in ambulatory care visit rates, which would, for us, imply that they were actually accessing some of the services a lot more than, say, those that did not. So basically being able to plug them into the right spots, if you will.
We had Joan Werblin next with a question.
Yeah, I'd like to play devil's advocate for a minute. One of the programs that my organization supervises is the MSSP, Multiple Senior Services Program. And, I understand, and I've had a grant from the pharmacy group and done a study, and I wholeheartedly love pharmacists on the team. But I've made home visits with our nurses and our social workers. And is anyone addressing, or can we as a group, if we're looking at community, that subset out there with probably numbers in the tens of thousands who do not have or haven't had in probably 10 years contact with a pharmacist? When I went out to visit some of our clients, one woman I counted, she had 36 bottles of pills sitting on her kitchen table. I looked at her record that we had. Half of them weren't on there. Some of them I didn't recognize what they were. I didn't have a PDR with me. And I said to the person, the teammate that I was with, we really should have a pharmacist with us. And I've talked to people from different pharmacy schools that I've met and said, do you have a way, or has anyone talked about getting you embedded in teams of visiting nurses, home health care, all these groups out here, and there are a lot of us, there are many, many MSSP programs up and down the state, who, you know, to be honest with you, I'm a nurse, and I sat there, and that was just one. The next woman had 20-some bottles. I didn't know what to do. I was concerned, I was frustrated. You know, so how do we get this talent and services out there?
You know, I think that's a really great question, and my work really at Mercy Medical Group, the last 2 years I was there, was doing exactly that, working on the home visit team, because we had patients who regularly had home visits, not just because they were home health or whatever.
Their meds are delivered to them, or a family member
But
picks them up.
I can tell you, until we get to telehealth, which we have to get to, we've got to figure that out, because it's very expensive to have people driving around during traffic hours to do home visits.
I
But
understand.
there
that.
is nothing more valuable than being in the home. I was called many times by the social worker saying, I can't find any pill bottles, and this guy's supposed to be on 12 different meds, and you go in the house, and all of them are dumped in a gold bowl, and the bottles are thrown away, and that's how they make it.
Yeah.
And the physician would never know that in an office visit.
Never.
So I totally agree with you that we have to embed people, pharmacists where people are cared, you know, where people live. And we've got to figure out a way to do it virtually. And we've got to figure out, maybe it's to put less expensive medical assistants in the home who have the equipment, because these people don't have it, for telehealth. And I walked them around. I did a system with my phone, had the patient walk around their home and show me everywhere they kept their meds. People's medication taking behaviors are very individual, and they impact how they're cared for.
And a lot of these don't have regular routine medical
Exactly.
follow-up. I mean, the prescriptions just get renewed and then added, and we've
But
got-
I don't think it's realistic. It's just like it's not realistic to put a nurse practitioner in every home
It's
either.
not, but
We've got to come up with better solutions to care for people where they live. So
or help for
you're
people going in the home.
preaching to the choir. You're 100%.
It's a wonderful conversation. We have one more presenter that will be addressing community pharmacy, Parisa Vatanka. And,
Yeah, I'll introduce Risa. I'd love to introduce Risa.
and we have a wonderful new thing happening in the Sacramento capital region, which is that Safeway has invested in clinical space in their stores for the pharmacists to be able to do that advanced practice pharmacy work if there are referrals and a payment stream to do that.
So it's my pleasure to introduce Risa Vatanka, Parisa, who's been a pharmacist for the last 21 years in a wide range of settings, including academia, hospital, ambulatory care, community pharmacy, and industry. Risa has dedicated her career to broadening the scope and advancing the quality of care provided by pharmacists. As the Pharmacy Strategic Alliance Manager at Safeway and an Assistant Clinical Professor at Ucsf, Risa builds alliances with internal and external partners to design, study, and implement innovative community pharmacy-based patient care models. She also creates professional education and training programs to support successful system-wide implementation of these patient care services. Risa's going to speak today on a great project that we did between UCSF and Safeway on a smoking cessation pilot in the community pharmacy domain nationwide. And then her partner, Stan Leung, who's in our Sacramento area, is going to talk about the new and innovative workspace and the things going on in it. So thank you, Risa.
Good afternoon. It is such a pleasure to be here. I can't even tell you, I'm just overwhelmed with joy to be in this room with each and every one of you. I have been, as Marilyn said, I've just committed my entire career to advancement of community pharmacy practice. And it all began when I was a student on a Navajo Indian reservation in Shiprock, New Mexico. And my eyes were opened by experiences like the one you just described, where I got to go out with the public health nurse and visit patients in their hogans. There's so much you learn when you go right where the patients live. And in that setting, I saw pharmacists working to the top of their training. There was interprofessional practice even back then, They already had patient care rooms. They already understood that it takes the support of the entire family. It's not just caring for the patient, but it's having the family. So when they would do medication consultations, they did bring in the extended family. It was actually through Indian Health Service that we learned the importance of interactive patient consultation, and because there was a true language barrier. But then we learned that even if you're speaking the same language, there could be miscommunication. And then that goes into my training at Ucsf and at Stanford, where again I saw pharmacists in the hospital setting and in the ambulatory care setting, again, utilize at the top of their training. It was so fantastic in those early days to be able to see pharmacists working. Rounds wouldn't begin, this is how I remember it, rounds wouldn't begin until the pharmacist was there. And together, in an interprofessional way, we would look at the patient and do what was best, putting the patient at the center as well. So such a pleasure to be in this room, because I know with all of you in this room, we are going to succeed. We are going to do what's right. And we will be able to meet CMS's triple aim of better health, better care, at a lower cost. I'm confident. So, I just want to really quickly, because I know my time is short, and I do want to primarily just focus on the smoke cessation study that we did with UCSF, and then I have my colleague Stan Lund come up and talk about MTM. But just at a glance, just in case there's anyone in the room who hasn't noticed what's been going on in community pharmacy in the last couple decades. Yes, we provide the medication therapy. Yes, our primary role is still medication use safety. That's right there. But we've gone beyond that. And you've noticed that in the last 10 plus years, what happens around flu season? We've re-socialized communities to know that you can go to your local grocery store, go to your local pharmacy and get a vaccine. We've actually helped to improve immunization rates in the communities that we serve. But we didn't just stop with that. It's all ACIP recommended immunizations, right? Tdap and Zostavax and meningococcal vaccine, all the different important vaccines, and we really do align with the Healthy People 2020 targets. So we are with you, physicians and nurses and other healthcare providers, we are working collaboratively with you to really make a difference in terms of health promotion, disease prevention. And so I will be speaking about smoking cessation, and I feel like really that's my dream. That what we have been able to accomplish in terms of a contribution to public health through immunizations, I hope that in a very few short years that we will have accomplished the same when it comes to helping people on their journey to stopping smoking. The dream is that it would just be known among healthcare providers and among communities that if you have someone who wants to stop smoking, you just go to your local pharmacy and there's this depot of information. They can help you with the medication, referral back to physician, if maybe you need prescription therapy, referral to tobacco quit lines, local support groups, and then to be there to coach you along. So that's the vision. Again, tobacco use being the #1 preventable cause of death. So to be able to do something there. In terms of patient education and monitoring, again, when we're providing the medication therapy, certainly we're educating and counseling on the proper use of that medication, but we're looking more broadly at what can we do to help patients, to activate the patient, to help them to be self-care managers of their condition. And so we've already begun implementing programs in diabetes, such as diabetes self-management education. We also will, at the close of this, discuss what else can we do? What are we doing for hypertension? What about blood pressure monitoring, dyslipidemia management. Another piece of what goes on in community pharmacy that I think is such a vital role, when I was working in the community pharmacy, and there would be someone over in the OTC aisle, I always felt like that was one of the most important things I could do, no matter how busy I was, filling prescriptions and immunizations and all the different things I was doing back there. If there was someone in the OTC aisle who needed my help, I'd run out there to go and talk to them. Because often, in the self-care area, that is the portal, the entryway into the healthcare system, because they may have seen no other healthcare provider. And they may be making self-care decisions without understanding how their underlying medical conditions or other medications that they're on could have an effect. And so certainly run out there, triage, determine, oops, no, this is not a self-treatment hour. You need to go back to your primary provider to be further evaluated and then come back to me. Or no, maybe it was an OTC product, but helping them with the right product. So another important piece of what we're doing in community. And then Again, with MTM, there's 2 different versions. There's the tips that we integrate into what we do each day, and then there's the comprehensive medication review that we do by appointment, which Stan will go over in detail. Okay, as we all know, since the 1964 Surgeon General report, we've done amazing things in terms of helping to decrease the number of smokers in this country. And the latest data that I looked at was 18% of the population. And in California, we can say, oh, well, we beat that. We're 12% of the population. But as many of you in this room know, it depends on which population in California you look at, because our Medi-Cal paid population is over 30% tobacco prevalence. So it depends on which patient population we're looking at. And any amount of tobacco use, as we all know, is too much. So we still have a long road to go, and I think that it's not going to take just one healthcare provider, but all of us working together to help to make this the generation that eliminates tobacco use, right? That's the big campaign. Be the generation to finish it, I think is the major campaign out right now. Also, certainly if I want to bring this in the context of cardiovascular disease, we all know tobacco has only complicates and takes many lives in terms of cardiovascular conditions. And even if we look at this data, when we look at the 18%, let's keep in mind the ripple effect of secondhand smoke. So it's really, the complications are even beyond just the current prevalence. I think there's great strides that we can still make here. All right, so Maryland, what did we do with UCSF? So a few years ago, we started talking about collaborating with UCSF to see how we could specifically work to expand the scope of what pharmacists were doing in terms of smoking cessation. So the question was, could we do it? It's a busy practice environment. Can we do this? So we conducted a randomized controlled trial in 20 pharmacies in California. It was only 12 weeks long. We put the 20 pharmacies into 2 groups. One group, we just gave them a best practices document, the tobacco treatment guidelines, and we said, oh, okay, make sure you ask all patients about tobacco use, advise them to quit, and refer them to the tobacco quit line. We just kind of left them. Will they embrace this? Well, certainly in pharmacy school, we saw a study all about smoking cessation medications and about how we should be engaged, as perhaps all healthcare providers learn about this. So was that enough, just to tell them, go ahead and start doing this? Or have another 10 where we also bring them in and we did a 4-hour training program, and we had our patient care services managers and others go out and coach and encourage our pharmacy teams to engage in this service. And so as a result of this program, I should say, we engaged our pharmacists, technicians, and clerks in the program. And we were able to reach 15,000 people and ask them their tobacco status. 1,300 were identified as tobacco smokers, and 1,200 of them received smoking cessation counseling and referred about over hundreds actually to the tobacco quit line. So we feel like this model was successful. And so as a company, we recognized the importance of this, and we decided to retool and develop a training that we could roll out throughout the country. And I'm proud to say that on January 1st, we rolled out our smoking cessation service to 1,000+ pharmacies nationwide. And I just want to take a moment to show you the model. Looks like we're running short on time.
We've got 17 minutes, and so why don't we give you 10 of those?
Okay. Okay. I don't want to take too much. Can I? Is that okay? Or 5? Even give me 5.
You get 3, so Stan can have 10.
Okay, good. Tell me when 3's up. And by the way, I'm short and I'm having to lean forward to reach.
So Parisa, we love what you're doing, and we think it's really important to get those messages out into the community. So if somebody wants to go to a Safeway and get smoking cessation, what does it cost them?
Oh, nothing. From us?
Yeah.
Yeah, nothing. What we've done is, I'll just really quickly the model. All we've done is we've said, look, when patients come when somebody approaches the pharmacy, just like we ask them their address, if they have insurance, we ask them their allergies, we now ask them, do you smoke or use any tobacco products? And we input that information in our computer system. Why do we do that? Because there's a whole page of medications that interact with tobacco smoke. We have been remiss as a profession that we haven't systematically asked each and every patient their tobacco status when we fill their prescriptions. That's medication use safety. How can we give hormone contraception out without asking their tobacco status? Because that right there could be a trigger to have the conversation with them and get somebody on the successful road to stopping smoking. So we've decided we are the first national community pharmacy chain to make this a standard of practice. And please tell all community pharmacies, we want this to be universal. This is a basic first step. Then second, the next and most important thing is once you know that somebody is a tobacco smoker, to advise them to quit. Have you ever thought about smoking? Have you ever tried to quit? And then if you're interested, we've got resources and we can help you. And then the next part of this model is, again, we're sticking to what pharmacists do. It's medication therapy. We understand that. So we can assess past quit attempts, help them with the right over-the-counter products, or if it's prescription, reach out to the provider to see if prescription medicine would be more appropriate. And then, very importantly, we know there's two parts to smoking, so there's two parts to quitting. The medication therapy for the nicotine addiction and behavioral counseling for breaking that habit of quitting. So I've reached out to 19 state tobacco quit lines in the states that we operate in, and they all became my best friends. And we've got this program now where we refer into the state tobacco quit lines. And so again, it's interprofessional practice. That's what they do best, and we stick to what we do best, and we're collaborating in that fashion. If I may also say, so not only have we made this a standard of practice of what we do for all our patients that are seen in the pharmacy, but we also thread this in extra into other things we do for our diabetes care services, for our behavioral health care services. When somebody comes in for an immunization, if they're a tobacco smoker, we're going to follow CDC guidelines and make sure they get the pneumonia vaccine. So we're not just, we're really threading this into everything that we do. I'll say as a pharmacist and pharmacy teams, we deal with benefits investigation all the time. And if there's medication access problems, if medication's too expensive, they won't stay with that quit attempt. So we also conduct benefits investigation to see if with a prescription we can get Medi-Cal coverage and other insurance coverages for the patient. I'll also share with you that when we do our smoking cessation services, we document it in our computer, and it generates 5 days later a report to remind us to call the patient and to check in to see how are they doing with the medication that we recommended, are they having nicotine withdrawal, any side effects, and also we check to see if they have indeed connected with the tobacco quit line. And if they haven't, we help to troubleshoot all those things. So we see this as a model that integrates into the busy community pharmacy setting, and it's very, we know we've got evidence that our pharmacists can engage in the service and can be successful doing this. One more before I close, because I'm so excited about this. Our pharmacy resident, may I? One more? Our pharmacy resident in Denver fulfilled my dream, one of my dreams this year. Turns out there's a tobacco performance, the Joint Commission has a tobacco performance measure on smoking cessation, right? And that we should be, during that amazing hospital stay, when somebody has stopped smoking, we are remiss if we do not say, would you like to stay? Stop, quit. Post-discharge. So the Joint Commission says, go ahead and ask if they're on the medication, refer them to the quit line, and check back in with them in 30 days. So the research study that we did this year, we had our pharmacy residents involved in providing this service in-house, but we also did a couple days post-discharge and 30 days and 90 days follow-up calls. So there's a lot that can be done. Community pharmacy is a great environment. Please don't forget your pharmacists in terms of these patient care programs. I think we can do a lot to achieve the health outcomes that we all hope to achieve. Thank you.
How about all of that? So today I'm going to touch on a little bit of the Safeway medication therapy management model. And our goal really is driving results and improve clinical outcome. From